Thank you, and thank the conference organizers for inviting me. It's truly an honor. I really love the intimacy of this and the real world problems that are being discussed. Interestingly, I was asked to talk about delivering care, and as you noted in my introduction, I do prevention. So I'm sort of upstream from care, and but I hope to be able to, some of what I'm going to have to skip through because everyone's already talked about it. But the trick is care. It's really all about care. Even for our prevention work, we deliver care. And I think that's what makes our study work. So everything I know about care, I know because we do it in the context of a couple of research studies. So basically, here's what I'm going to talk about today, and unless you want to see a few slides that are replicated from others and some of my really cool pictures, you can leave. These are my major points. But we all know that people who are injecting drugs are the population most affected, and that they're actually rarely treated. There's a sort of dichotomy between research and reality. We try to overcome that a little bit. The evidence is obviously, there is evidence that people who inject drugs can adhere and complete effective treatment, but there's also evidence that drug use impacts adherence and SVR. People who inject drugs are actually affected by numerous issues: substance use, alcohol, mental health, and that was the title that I was given to talk to you about. All of these issues impact reality, and I'm struck by all of the words that we use to describe the issues: comorbidity, depressive symptoms. It's a singularly invigorating and tragic situation when we're working with people who inject drugs who we're trying to give care to. And it's a challenging thing every day for everyone. But Hep C presents a new paradigm for us to address this with. New treatments really offer a lot of hope of increased access and population level impact. But I think that there's a lot of thought experiments out there that haven't really addressed the reality of what we're going to have to do to get there. I was struck by someone saying that we actually have a plan in the United States. We do. We have a priority plan, but we just don't have any money to implement it. So actually, we do need a lot of research, and we need a lot of strategy, and we need a lot of work to really figure out how to enhance access and treatment of Hep C if we're going to really see population level impacts. And so these I can skip through because they've been given to me, and you've seen them already all day today. The reservoir of infection in new infections is in drug users. In San Francisco, we capture new infections. We screen people. I get 1, 2, or 3 new infections a month in my cohort, and most of them are about 25 years old. They've been injecting about 2 to 5 years. This one we've also seen Scott Holmberg's work showing the cascade of care. But let's talk about the incredible shrinking patient when we talk about people who inject drugs. Treatment of injectors or people who inject drugs has actually been controversial, as we all know, especially with interferon-based regimens. This actually is adapted from Holly Hagen's work, which showing the diminished percentage of HCV-positive injectors who are eligible for HCV treatment when various criteria are applied, including audit scores below at or equal to 18, and audit and Beck depression inventory scores about less than 19. The proportion of injectors who are eligible for treatment based on laboratory, psychiatric, and behavioral data, and this is just a small amount of data, at the end of her study was 4%. If we use criteria whereby people who've been injecting for the last 6 months are excluded, it goes to 0. In real life, treatment eligibility is actually based on probably many additional criteria, including stages of change, PTSD, screening, social support, and we've heard that today, additional lab and blood chemistry criteria. Clinicians may consider housing and ability to attend appointments. All of these things contribute to the incredible shrinking patient. I will tell you that in my 12 years of identifying people with hepatitis C in San Francisco, screening over 1,200 people and capturing 500 prevalent infections and 150 acute infections, not one person has ever received treatment. They've all been referred. So Hep C treatment works. It leads to viral suppression. It reduces the likelihood of liver disease. It reduces the likelihood of liver-related adverse outcomes, and it reduces mortality by half. So it's really important that we start to treat people to reduce the reservoir of infection. Hep C treatment of former and current injectors can be effective. This is a brief summary. We know that SVR rates are comparable in a range of studies. Most of these are quite small. Adherence is very important. There's this sort of 80% rule associated with treatment failure. There's mixed results regarding drug use effects on adherence and treatment completion. Any drug use history may reduce, but it may also have no impact on adherence or completion. So a lot of these things go back and forth. They may reduce recent use at treatment initiation. But frequency tends to impact adherence, and adherence impacts SVR based on all the old stuff, right? Now we've got the new ones coming. But other factors that impact SVR are poor social functioning, untreated depression, ongoing drug use, education and housing issues. So I'm going to show you a little bit of data, and my data is mostly in young adult injectors because that's who I collect data on, and I think it sort of brings to light real world stuff here. The UFO study is a large ongoing prospective cohort, observational cohort of young adult injectors, and we do a lot of really interesting stuff, but mostly we're open 2 days a week, every week of the year, whether it's Christmas, Thanksgiving, New Year's. We have an amazing facility in the heart of the Tenderloin. If you're asking yourself right now, what does UFO stand for? It stands for You Find Out. So let me tell you about substance use. We have a lot, all of our folks are injectors. That's a criteria for entry. They use mostly heroin, but they also use a lot of other substances. And these are just the single substances. Polysubstance use is also really high. 61% of, among heroin users, 61% use speed occasionally in the last 3 months. 62% have used crack, and 29% have used cocaine. So it's not just, it's polydrug use. I've got guys who inject bourbon. Speaking of alcohol use, heavy alcohol use is related to severe liver disease, and it can also reduce the effectiveness of treatment. In our population, alcohol use is really gnarly. It's really prevalent. And we recently have assessed alcohol use using the audit. Probable dependence score was 10 to 12, hazardous drinking 3 to 9 for women and 4 to 9 for men. Almost all, 85% of probable dependent, and I just don't have a cute little thing here, but the sort of mustard colored guys, almost all of them reported drinking 6 or more drinks on one occasion, daily or almost daily. The remaining reported this much in 1 week. So, and then the amount of binge drinking and drinking to blackouts is really high. We really haven't even begun to address this at all in our population. We've got them going to needle exchange, we're giving them buprenorphine, but we don't even know what we're doing here at this point. And by the way, we've corroborated this using biomarkers recently. But these things also are associated with risk behaviors. People who drink a lot, actually, they have a little bit less injection frequency, but they're more likely to share. And we know that drinking impacts adherence to many medical interventions, including HIV and other illnesses. We're also concerned about adherence. Okay, psychiatric comorbidities. These are the co-occurring disorders, and in brief, a lot of people who have in the U.S., 9.2 million people with co-occurring mental and health substance diagnosis, only 44% received care. That's where I'm going to sort of go with this, because we know there's a lot of it, but how many of them are actually getting any care? Co-occurring diagnosis is really high. It's the highest in the youngest group, especially those people that we see, and very few people have looked at it. So we thought we'd do a sub-study to look at mental health. And it took us a really long time to set this up because we had to work with some psychologists, and there's a lot of process involved. And we didn't want psychologists at the study site, so we had them train our counselors in administering the mini, and then we have a whole referral system set up. In this case, for the past 2 years, we've invited folks to participate in this sub-study. And this is sort of what they look like. They're about 25 years old, mostly male, mostly white. 2/3 of them have come out of high school. A lot of them are homeless, and a lot of them report a mental health diagnosis by self-report. This really looks a lot like most of our UFO people. So this is what we found. We actually administered the mini mental health, four components of the mini mental health, and I'm actually missing one of my speaker notes here, but what I can tell you is that of those 340 some odd people, only 150 accepted to participate. They don't want to get diagnosed, and they don't want to participate in getting their mental health issues addressed. And that was our biggest problem, was the lack of participation. So this reflects quite a biased sample. All right, but you can see we have a very high proportion of people who have had a lifetime episode of major depressive disorder. We also have a lot of people who report suicidal feelings. We have a significant number who report mania and social anxiety. And this is just 4 little aspects of the mini, because it takes a long time to administer. You have to pay them a lot of money if you want them to stay for a long time, and they just can't do it. So doing psychological evaluation is really challenging because of that time. What we also found was that people who have who self-report diagnoses, so we did the mini, but we also did sort of like, have you ever been diagnosed, by self-report. And those who report having been diagnosed, and a lot of them do, actually only 34% of those who have any previous diagnosis report getting any mental health counseling in the past 3 months. Despite this, things that were associated with getting mental health counseling were being older, people who had depression, anxiety, or PTSD, or were taking any medication. That's really good if you're taking medication and someone's counseling you, because some of our folks take medication and they're not getting anything except some. So we were happy that some people are actually accessing services who need that. But we also found that getting, on a less optimistic note, that people who had mental health diagnoses actually had a high frequency of risk behaviors as well. The opposite. People who were getting mental health counseling were less likely to be injecting every day, less likely to be using heroin, less likely to share, and people who were HCV positive were more likely to be getting counseling. We were actually really happy about that as well. And these HCV positive diagnoses were not just supplied by us, but by others. So just to kind of summarize, for our population, the majority of these young injectors do have major depression. They have a high amount of post-traumatic stress disorder, and only 1/3 of those with any previous diagnoses are getting any history of mental health counseling in the last 3 months. And even though we offer it, they don't always take us up on it. So I put life here, but maybe I should have put issues, since I'm kind of focusing in on the lexicon. Treatment candidacy for HCV infection is not just impacted by physiological factors, addiction, and mental health, but a host of other psychosocial factors. Housing status, lack of social support, incarceration, and access to health care have significant impacts. Among our participants, 3/4 have been unstably housed or homeless in the last 3 months. A lot of them travel. We have a phenomenon in the United States of travelers, and they kind of do this circuit. They go from Portland to San Francisco to LA over to maybe New Orleans or something, and then they come back. Or they plan to travel. They don't always, but they plan to. And that impacts, our recruitment of them. And then 1 in 4 has been incarcerated in the last 3 months. And that ranges from 2 days to a month in general. But those things impact access to and adherence to all kinds of care. So, how are we going to actually deliver and maximize treatment? We have all the solutions have been discussed here. I really don't have much to add. We're talking about the changing landscape. This was then. Now, this is now. We are getting new drugs. There's a lot of optimism about the potential for treating people who inject drugs. In fact, there are some people who think it's the end of Hep C. The treatment as prevention model is being proposed as feasible, and I'm actually a terminal optimist, so I do think it's feasible, but I'm also on the reality side. This is a model by Natasha Martin. It's been shown several times today. It feeds this type of thought experiment, feeds the hope and the prospect that we can actually impact population prevalence using Hep C treatment. We could reduce hepatitis C over 10 years by between 20 and 60%, depending on baseline chronic infection. But thought experiments are not magic beans. And so far, I like thought experiments. I'm a fan of modeling, but modeling's great because it helps to impact policy. And I think Scotland is a fantastic example of that. There are more than, incidence has actually gone down. It's remarkable. But we know, so what can we really do to make these thought experiments reality? And that's the challenge that I keep hearing here today. And these are all of the things that people want to do: enhanced screening and diagnosis, HCV testing and test counselor training. These are some of the challenges that we face in the United States. And I think this will address some of what was brought up by the last questioner. HCV testing and screening is rare at agencies and local health departments because of lack of funding. Everything in the United States is tied to HIV, and young injectors we don't have much HIV. Tying everything that they do to HIV increases stigma and increases lack of participation. There was an incredible little study that I found done by a guy at the California Department of Public Health where they offered Hep C testing before HIV testing. It increased HIV testing by 50%, and it increased people coming back for their HIV results by 200%. Simply by not offering HIV testing first, but offering Hep C testing first. The new testing technologies, the rapid testing in local and community settings, is also giving us great opportunities. Early looks at our data in the UFO study suggest that the rapid testing is associated with more rapid change in behavior because they're getting the results within 20 minutes and not 1 week. And they get their RNA results, because we give everyone an RNA result, within 1 week instead of 2 weeks. If we can reduce that 1 week even further with our RNA results, we might actually see more impact on behavior. So we do need more testing strategies that are rapid and that give people real information about their infection status. So dry blood strategies are something that we're all looking into, and that is what they're using in Scotland. They're using an in-house assay to get RNA results. We use a rapid NAT testing to do the same thing. And it's really cheap, and we just got a laboratory. Instead of paying $200, we negotiated a lower price for rapid RNA testing. So we need new strategies, and we need real linkage to care that counts. It's not about HIV, it's about Hep C. And no, they don't want STD tests, and they don't want mental health counseling. They just want to get their HCV test. That's the gateway in. In California, they've now tied the rapid HCV testing to HIV testing by demanding that it only be done by HIV counselors. So it's just one obstacle after another. Obviously, we need more education and outreach, and basically, I think this isn't just for patients, but also for physicians. We need people to actually use the evidence-based guidelines between communities across countries and follow evidence. And there needs to be infrastructure for HCV services, not HIV services, HCV services. Prevalence of HIV in my population, by the way, is about 3%. Engagement, we've heard a lot about this today. These are common themes here. Lots of models, whatever works, whatever floats your boat, your participant's boat. The common theme, though, is systematically addressing not just HCV, but these issues. And the way we address those is with care. We actually care about our participants. Enhancing response, check off the tolerable, simple, short duration. Models to maximize adherence, I think, are important, and that's been brought up as well, different models. Patient navigator incentivization. We need risk reduction to prevent reinfection. But really, we need a lot of patience for our patients, because getting people ready for HCV treatment is a lot of work. This is the message. Change your life if you want to get Hep C treatment. And very often they're told to do this very quickly. We did a very nice study on hepatitis C treatment candidacy a few years ago, and granted, again, the interferon thing sort of confounds everything that we know now. You know, we have that pretty new landscape, but it was impossible. This is actually more about what it's like for them. We had a guy who after he got into drug treatment, and he was acute, and back then we were thinking of treating acute people, you know, and he got into drug treatment, and he was clean, and you know, he got stable housing, but the specialist said, well, he doesn't have a cell phone. Okay, we got him a cell phone. And at the next meeting, it was you know, my team, I was there, the specialist says, well, he's in school. I don't want to upset his school thing. And I just looked, I said, who does he have to fuck? You know, for you to treat this guy. He's done everything you asked him. He's changed his life, and it wasn't easy. Housing's a really big issue in San Francisco, and actually I just read a really interesting protocol, the San Francisco Department of Public Health, and we do have a universal health system in San Francisco, is providing supportive housing now to 300 street-based youth, age 18 to 24. It'll be interesting to see what the results of that are, because, and they're going to do an evaluation. I think that'll be really interesting to look at. UFO then uses a model, and this is, I guess, what I can share with you. How much time do I have? Oh, okay. I'll just keep going. You can tell me. So you know,
8 minutes.
Okay, we're okay then. So the UFO study has been ongoing for a while. NIH funds us. And, you know, we started off with nothing, and we didn't have guidelines. We were detecting acute infection. We're doing this RNA testing, and a few years ago, the CDC gave us some money to actually write up the things that we were already doing but never got paid to write up, you know? Like, how do we do outreach, and what's our counseling message, and how do you do a rapid Hep C test in a community-based setting? So we called it the Project UFO Presents, and we actually have a replication manual, and we have a website and all those things, and we farmed it out to a couple of agencies that are dealing with young people at risk of Hep C for them to test this in terms of their outreach. It's a sort of, you know, everyone, the multi, what we're all doing, education and prevention intervention. We are really focused on young adult IDU because they have really high risk for everything. It's been tested now in Newark. And it's been tested in Sacramento. And I still want to emphasize that the missing thing here is care, you know. Sometimes someone just walks in and, you know, how are you? We actually try to provide care. It's not easy. Sometimes the staff we have to do a lot of work with the staff too, because sometimes there is some burnout. The core elements are obviously a harm reduction philosophy, and I actually personally hate the word harm reduction. I think it's an umbrella term for anything you want it to be, but it is. It's anything you want it to be as long as you're nice and you care. We presented this at a summit in Washington, D.C., and a woman got up and said, "What's your theoretical model?" I said, "We don't have one. We're just nice. We're kind. We have an open door, and we have food, and we have socks, and we have hats, and you can bring your dog. There's no theoretical model." It's a youth-centered focus, and we do a lot of outreach, and there's a lot of consistency in our outreach. And we do a lot of collaborations and referrals. We work really closely with our health department. We try to be there. The UFO study is the primary provider of prevention and primary care services in San Francisco for young adult people who inject drugs. We provide abscesses. We've got a nurse on site. We provide primary care referrals, and we will walk them through to the referral, make the appointment, show up with them. And we do that so that we could make our research work. And in the process, we found out what makes it work. You know, being there for young people and showing compassion and being accepting are all really important. And I think that's what harm reduction is. It's that compassion and acceptance. The components of our UFO model, we like to tell people who want to use it because it's on the web, is that it's modular. You use what you can, use what you can afford. All of these things are part of it. Youth-centered referrals, we have a resource book that we update twice a year so that we know where to send people. We provide syringes, even though we are a federally funded site. We've found the health department is not, and they give us stuff to provide. We have immunizations year-round, including for seasonal infections. We're doing tetanus and all kinds of things. So it is primary care, and we have a suitcase clinic. That's how we do our Tylenol, Neosporin. This shows you it's just ufomodel.org if you want to access it. And the really cool thing is some of our little movies. I really like those where we talk about some of the issues because not everyone wants to read, so you can watch things. But so there's a lot of details on that. We get it, and we design this so people can use it. That's how we deliver care with care. And I want to thank everyone, my study team, the NIH and the CDC for funding, Jason for slides, which I skipped over quickly, and all of the young people who participate and help to spread the word. Thank you.
Thank you very much, Kim. I think we have some time for some questions if anyone has. And while people are coming up to the mic, I liked one of the concepts you kind of quickly went over, and that's the gateway concept. And I wondered what you thought about that in terms of hooking people into the other aspects of care that really are needing, whether Hep C has a role in that. And certainly something we started to observe is that people who go through treatment or engage in treatment actually start to make a lot of other changes in their lives, and possibly due to the fact that they've received care now in a broader sense.
Well, I like that question because I'm not a psychologist or a clinician. But what we learned when we did our treatment candidacy study was we have a way of analyzing data called competing risks. What I found out when we started looking at our young injectors who were getting Hep C, and even the people who come in who are chronically infected, who we take care of, they have competing priorities. So when you put it all on the table, housing, mental health, prenatal care, they'll actually choose something else before they'll choose Hep C. And that, of course, has to do with the toxicities. I mean, as we do education, it's not easy to go through treatment, and people are going to want you to commit to changing your life today. But so people are opting. We have a lot of people in treatment. We have more people going into treatment than dying of overdose. And I think that's a really good thing. It's sort of like more SVRs than new infections. We do. We have more people going into buprenorphine treatment. And we recently analyzed data and found that buprenorphine is associated with reducing our incidence infection by 1/2 in our young injectors. So it's really important. So I don't see that they're getting care because of Hep C. They're getting care because of Hep C treatment. They're getting care because they got Hep C and they're being made aware of their options. And San Francisco has a great health plan.
Yeah, thanks. Mark Tyndall. I just had a question to compare what's happening in a place like San Francisco and what's happening in big cities in Canada as far as policies around harm reduction that you kind of dissed off a little bit. But how we're going to...
It's not really a diss. It's
how
just,
we're going to
how
we're going to prevent new infections. So, and it relates a little bit back to what the PIAC person was talking about, in that we're in an environment where we can't seem to get people a 10-cent needle to prevent an infection, but we're arguing that they need $80,000 treatment. So we're really fighting against ourselves in Canada in many respects, where we seem to be going backwards as far as prevention, and the whole, the war on drugs and criminality. And in your cohort, 1 in 4 people have been in jail the last 6 months or whatever. So we're really fighting an uphill battle here. We really are. And there's a lot of things that we could do better in Canada. And I wonder if there's any lessons from what you're facing in San Francisco as far as how you deal with enforcement and harm reduction.
I wish we could be Canada and San Francisco.
No, I don't think so.
No? Well, every year, Congress has to reauthorize or deauthorize funding for needles. We run into all kinds of policing issues, and even though we do have policies that decriminalize possession is criminalized. And so we have that dichotomy that continues to work against us all the time. And and it's really not a diss of harm reduction. It's just at some point it needs to be meaningful. Water for meth users, to me, it just is not harm reduction. And then sometimes that's all that people have to propose. But harm reduction in San Francisco is alive and well. And it's alive and well because of activists and because of money that isn't, oops, did I turn that off? Because of money that isn't federal and because of political will. So I don't know what to do.
It's okay. Your time.
Hello? Oh. I was at a recent meeting where a guy from South Carolina, and we have a trend now in the United States for young injectors. We have these outbreaks of Hep C in urban and suburban and rural areas that are happening because there is no needle exchange, there is no services, there is nothing. I mean, in San Francisco, we've got good services. We have problems, but we have stay away orders, and the cops round them up. The same problems, and they don't have needle exchange in these places. And I said, well, why don't you get a needle exchange to start with? And he goes, well, I can't do that. I'd go to jail. They'll run me out of town. I said, you know what? People went to jail in San Francisco and in California and in Oregon and in other places. They went to jail to have that. And, people went to jail for this political research for HIV. But we don't really have that kind of political will around drug users. And that's always a sort of fighting upstream, swimming upstream problem. And it's a day-to-day thing.
Thank you very much. I think we have to stop there.